All right, so I'm going to talk about coronary CT in outpatient population. The first common questions: who should get it, why we do it, and how it benefits the patients. So we have the appropriate criteria for coronary CT, and it's basically coronary CT is considered appropriate for patients with low to intermediate pretest probability, and as you know better than I do, pretest probability is determined based on patient's sex, age, and symptoms. It's basically independent of, hypertension or diabetes and all these things. For me, it's always easier to think who coronary CT is not appropriate for, because every man over 40, coronary CT is appropriate for, regardless of them having symptoms or not. And every woman over 60 is, appropriate regardless of them having symptoms or not. So it's basically inappropriate only in, younger female patients who don't really have any symptoms. And every person who does have symptoms, it is considered appropriate. Why is coronary CT a good test for patients with suspected coronary artery disease? First of all, it's a very sensitive test. It has a very, very high negative predictive value. So basically, if it's negative, there is no coronary artery disease. So it allows us to do early detection of coronary artery disease. So we are basically looking at the whole coronary anatomy so we can determine what's the extent of the disease, how severe the disease is, and it allows us to decide on the treatment options that we have for the patient. How it helps us? Basically, when we look at the coronary CT, we can decide whether there is atherosclerosis or there is no atherosclerosis. If there is no atherosclerosis, it's very easy. Basically, we can send the patient, we can reassure the patient, send them home and say, well, if you have these symptoms for the next 3 to 5 years, it's not originating from your heart. So it's basically very helpful for reassurance to the patient, especially the ones who are very anxious. If there is atherosclerosis, then if it's less than 50% narrowing, these patients need medical treatment. They don't need any further testing. But if we have disease which is more than 50% narrowing, then patients need further testing, as Andrew mentioned. For example, they need MPI to see if it's significant narrowing or not, and then we can decide whether the patients need, say, PCI or surgery, or they need optical medical therapy. So I'm going to show 4 cases, basically bread and butter cases. These 4 cases I saw within 2 days of reading coronary CTs. So the first one is a 42-year-old man. His pretest probability is considered low because his age is 42 and he has no chest pain. And this is the requisition that I got. It says that this person has abnormal ECG, abnormal exercise test, he's anxious, and he has palpitations but no chest pain. I think this must be a common scenario in clinical practice. So he comes in for a coronary CT, and these are his images. As you can see, all the coronary arteries are normal, and this patient can stop worrying. The physician can stop worrying, can send the patient home, we can give reassurance, and there is no coronary artery disease. I don't think there is any treatment except for, lifestyle managements and all that. The second case is a 50-year-old man who does have chest pain, and his pretest probability is intermediate, so obviously coronary CT is appropriate. This patient has chest pain, and he had some kind of ischemia and MIBI. He is a truck driver, and he's off his job while significance is determined. I put the sheet below just so you have an idea how it's done. So patients come in for coronary CT, they are usually given a dose of beta blockers. If they are not on beta blocker, they take the dose before they come in, and if they come in, their heart rate's below 60, it's very easy. They just go and have their test done. They just get an IV, they get the contrast, they get a test done. It's very easy. If the heart rate is over 60, then we give them an extra dose of beta blockers. So I guess this patient came in with heart rate of 53. I didn't really have to do anything. They just called me and I said, okay, go ahead, do the CT. They did the CT. And these are the coronary arteries. All the 3 coronary arteries are normal. I guess the defect on the MIBI was a false negative and can go back to work. So the question answered, it's quite easy. My third case is a 43-year-old man who has some atypical chest pain. Again, it's an intermediate pretest probability, which is appropriate. And this is the history that I got. It says a 43-year-old man with type 2 diabetes. He's on insulin. ECG is negative. Perfusion is negative. It's interesting. The test is ordered to rule out false negative MIBI. So, sometimes we have patients worrying, but a lot of times we have physicians worrying. And I think it's for a good reason, because this patient's diabetic. He's on insulin, and they want to make sure that it wasn't a false negative maybe. And again, we did the CT, perfectly normal coronary arteries, and the problem is solved. My last case is a 44-year-old man who has chest pains, and his pretest probability is intermediate. So this is an interesting story. He did have a MIBI done, a perfusion study for him, and there was cardiac ischemia in the inferior wall. I just want to show you a part of the clinic letter that was sent to us by a cardiologist. So I'm just going to read a part of this clinic letter. It's, this man had a small amount of ischemia in the inferior wall, and in order to clarify, I've ordered coronary CT. If there is no evidence of any atherosclerosis, then we're not going to do anything further. But if there is coronary atherosclerosis, then we're going to have the cholesterol below 2, and also we're going to start ACE inhibitors just to protect his coronary arteries. So this is basically how coronary CT is going to help us with the decision in a person who doesn't really have typical symptoms, and we don't know if there is actually any coronary artery disease or not. So we did the coronary CT, and we got these images. So I just put it in there to just show that it's really not that easy. I know coronary arteries are just pipes, as people call them, and it should be quite easy, but the strength of coronary CT is picking up tiny disease that otherwise would be missed on any other imaging studies. And if you look carefully, you have actually a plaque just at the origin of the LAD. It's not a significant plaque. This would not cause any defect on MPI, like this is 20, 25%, 30% narrowing. But it means that there is definitely coronary artery disease. This means that this patient's LDL has to be very low. This means that the patient's probably going to get ACE inhibitors to protect his coronary arteries. And it's important to know that if we had done a calcium score for this person, this plaque is not calcified. It would be negative. Like the calcium score was 0 in this patient, even though there was a plaque and it was the indicator of presence of coronary artery disease. All right, so this patient is going to get medical treatment, as we saw from the clinic letter.